Cool. Well, thanks for everyone for coming in person and at Zoom. I'm Jason Fletcher in the La Follette School, and I'd like to welcome Sebastian Tello-Trillo here to UW-Madison for the full week. He's has degrees in economics from Florida State and Vanderbilt, and joined UVA after his PhD in 2016 at Vanderbilt. He's also a member of the NBER. He's an expert in health economics and health policy, especially the economics of health insurance for both mental and physical health outcomes. We'll see some of that today. He's published 8 papers and has many working papers, and I counted at least 15 different co-authors. He's got a huge network for a great scholar. The key thing I wanted to say is that he's visiting CDHA the whole week, and he has at least 25 meetings already set, but he does have room in his schedule, including the talk. And he's going to be going all around campus. He has the talk today, and he has a talk in the demography seminar tomorrow, I'll plug, called Health Insurance for Whom: The Spill-Up Effects of Children's Health Insurance on Mothers. He's also giving a PhD graduate training seminar on the topic of the hidden curriculum, which is also the title of his podcast. So he's a very busy person, but he still has some time to meet with you all here. So please get in touch if you'd like to schedule a meeting later in the week. And with that, I'd like for the people in the room and on Zoom to welcome Dr. Tello-Trillo to Madison.
Thank you. Thanks for that introduction. Yeah, this is great. I'm so excited to be here for the week. I think this is something that we schedule during my sabbatical, but then also it was during the pandemic. And so we had to kick it back. And I'm actually really happy that we got it to work out and that I can come here and meet so many people doing really, really cool work. So today I'm going to present you work that is co-authored with Catherine McLean and Doug Weber. They're both at Temple. And this is about losing health insurance and its effects on mental health. All right, let's get started. See here. And so I think I'll just go to presentations, and hopefully we'll have a conversation at the end for comments, stuff like that. But if there's any clarification that you want while I'm presenting, I'm happy to give it. And I'm also looking at the chat for the Zoom people as well. Okay, so there has been a breadth of evidence in many literatures, not just in economics, but also in like health and clinicals, about the effects of public health insurance on a number of health measures. You name it, like access, healthcare utilization, employment, and so on. So there's a lot of literature that we already have on this. And there's more recent literature that has been developed that focuses on mental health outcomes. Now, when we started writing this paper, I think it was like about 2 years ago, I think there weren't as many. Now there's just a very explosive number of papers that are focused on this, which I think is like 2 thumbs up. I think it's awesome, and we probably should see more. And I think this is an interesting kind of like little subfield within the health field. And I think something that's important to highlight of why the mental health case is particularly important to study kind of differently. I think there's a lot of number of reasons, and you can have economic arguments that talk about like a rational model of an agent that will motivate it. I think the simpler way to understand is mental health is very much different than physical health. We don't get the acute measurements that we have as in physical health, like a fever or weight or anything like that. And there's also a lot less coverage for mental health than there are for physical health. And the training and the licensing part of the training is also very different. So it encompasses a number of different aspects that make it a particularly really interesting type of condition to study. And so that's one of the reasons why we're focusing on it. So the research question is very straightforward here. What is the effect of contracting public health insurance on mental health care and mental illness? In order to study this, we're going to use the 10-care disenrollment, which is a reform that I'll talk about that happened in 2005, in which about 190K individuals lost Medicaid eligibility due to budget cuts. With a straightforward difference strategy to see before and after, comparing to a control group, and we're going to use some admin data and that we have available from different places. So the key thing here is that what we're doing is, the little innovative part maybe that we're doing is that we're studying a contraction in public health eligibility rather than an expansion. And the reason why this is a little bit interesting is because a lot of the papers that we seen and that help us understand the relationship between health insurance and you name the outcome comes from the Massachusetts healthcare reform, the Oregon health insurance experiment, the ACA Medicaid expansions, the Medicaid expansions from throughout the 80s and the 90s. And all of these are expansions, right? All of these are people gaining health insurance as opposed to people losing health insurance. And you can think of many reasons why the effects may not necessarily be symmetric. And you know, within that context, you can think of that, but also just like more broadly and theoretically, there's now this whole new literature developing in kind of like the DD world about heterogeneous treatment effects. And so this is just kind of like part of that literature, right? That an effect may be not long lasting and taking is different than losing. The other innovation that we are doing in this paper is a little bit more methodological, and I actually won't go too much into detail on this, but we have like a big data appendix, is how we can implement a strategy for obtaining doing a single estate analysis using this particular data set, which is called the nationwide inpatient sample. The big point here is that this is a not state representative sample, and we're using it for a state representative, and we'll tell you how we do it in a couple of slides. So in terms of prior literature, we can kind of focus our attention into some papers that talk about this 10K reform and papers that talk about expansions and mental health outcomes. I definitely need to update some of these slides in the sense that there is now new papers, and I know there's people in the audience that have papers on this, so I definitely need to revamp that part. But I won't really focus too much right now on the literature. There has been some therapeutic papers that others and myself had written. This is not necessarily a new type of thing that no one else has studied. There's been a number of people who have been studying, and in terms of effects on employment, healthcare utilization, financial outcomes, etc. There's also a breadth of literature on expansions, people gaining insurance, and mental health outcomes. And mostly, I think the summary that I would say has been somewhat found in is that decreases in healthcare or insurance lead to decreases in healthcare access for mental health in terms of medication utilization. When it comes to actual levels of mental health, however we define those, I think it's a little bit more mixed. I don't know if I don't think my interpretation of the literature is that it's mixed because there's positive and negative. I think it's mixed in the sense that sometimes it's actually really hard to find a precise and clean effect. And that should not be surprising when studying mental health. Okay, so let me talk about the 10K reform so we all understand what exactly is that I'm studying here. So before 1994, a significant portion of the Medicaid funding from Tennessee came from this special tax that they had on hospital. And they knew that this was going to expire in 1994. So it was just a way that the state was funding its Medicaid, or the portion of the Medicaid that they need to pay. And as it was going to expire, they need to have the conversation of okay, what are we going to do for the next 10 years? Are we going to keep doing the tax or not? There was some, I wouldn't say contract, but expectation that the tax was not going to get renewed. And I believe this is back when the tax was instated, of the reasons why they're not going to do it. So there was a governor race, and Governor McWhorter got elected. He was a Dem. And his big idea was to do three things. Either A, we're going to increase taxes in different settings. Either B, we're going to reduce provider reimbursement rates. We're going to pay doctors and providers less. Or we do this massive overhaul of the healthcare delivery system in Tennessee. And the goals of any of this reform was to do two things. So cost control, I keep costs down or lower, and also to expand public health insurance eligibility. So if you think about the 94 context, in the United States at least, there was this trend and push for a big healthcare reform led by Hillary Clinton. And so this was kind of in the air, and Governor McWhorter kind of went for that and pushed this kind of big reform of healthcare in Tennessee. So what were the big ideas? The big ideas is let's enroll everyone in Medicaid that we have here on a managed organization system, an MCO. We're going to pay them a per capita fee per person, right? And that means that we're not going to have these volatile changes in expenditures. And so the money that we save, we're going to use it to expand eligibility for everyone else, right? So before, maybe I was paying $20 for this person and $100 for this person. Now with an MCO, I'm going to pay maybe $50 for everyone. And hopefully I'm saving money with that. And that money I'm going to use to expand eligibility. That was the big healthcare reform plan in kind of in a nutshell. And who did they expand eligibility? There's two sets of people: individuals with incomes up to 400% of the FPL, so they were going to get access to Medicaid, and also childless adults. The big difference between these two groups is that for people with income up to 400 FPL, which is very generous for Medicaid, there was a scale of also premiums and deductibles, so it wasn't exactly full traditional Medicaid as expected. However, for childless adults, if you're in the whatever FPL that is regular Medicaid, you get full traditional Medicaid. So this is actually one of the first states to expand to childless adults Medicaid eligibility, which I would not have expected of Tennessee to do, or at least in the context that I know of Tennessee. Now, I don't say the first, because as far as I know, the first one was California, and it wasn't through Medicaid properly, but through a program that they created to provide healthcare rather than health insurance to childless adults. So because that was embedded into the insurance program, that could be considered the first historically. But this is the more proper regular Medicaid expansion to childless adults. The other important thing to keep in mind here, and you'll see this in the stats, is that even though the expansion was done to that group of 400 FPL, that was really not where the action was, in the sense that a lot of those people already had insurance from their employers, or they didn't think that they want to pay for Medicaid and so on. So really the big group that took it up, or that made the big change, is the eligibility on the childless adults. So they did this, they restructured it, childless adults became eligible, a bunch of people signed up, and things kept going. By the early 2000s, the state government ran into budget deficits as they were running. And one of the proposals was to reverse that healthcare expansion that we had, or that Tennessee had in 1994. There is a number of back and forth and political economy things that I'm not summarizing here, but I think the most important thing to know is that there is a lot of conversation of what to do to keep this deficit down, and they were attributing the higher expenditures of Medicaid for the reason of the deficit. And Governor Bretzen, after an election as well, that ran in with the whole idea of, I'm a healthcare CEO, I know how to handle these things, I'm gonna get things under control. He won, and his big idea was to terminate the medical eligibility for the people who were expanded in 1994. So, I mean, it was pretty simple, right? If we want to cost control, we kick people out, and that's how we're gonna save money. So about 170 to 230,000 Tennessee residents were dropped from TennCare due to budget deficits. This estimate has that range because even with the admin data, it's kind of hard to know exactly the number, but this is a pretty good approximation. Garthwaite, this is another paper, estimates that 90% of the individuals were dropped were childless adults. And this is about 4 to 6% of the non-elderly population of Tennessee as a whole lost public health insurance eligibility. If we look at out of the Medicaid population, that looks like about 20-ish% of people in Medicaid lost coverage. Another important thing as an economist that I should care about is money. One question that I get asked is like, well, how much did the state save money, right? So they're very unclear on the reports of how much they were saving. So let me give you two different numbers, and you can think that the numbers between this range. So the average cost per enrollee around 2004 and 5 was about $5,200. This is the number of people who were disenrolled. So if I just multiply that number, I get 900 million. But the state doesn't pay those 900 million, right? The state pays 35 of that because it's a joint effort between the state and the federal government. So in that sense, if we use that math, is about $300 million, or $300 million? Yeah, I think so. I think that's the right way to say that number, is that they saved. Another way of looking at this number is just to compare the state expenditures between one year and the other one. And that gives you a higher upper bound of about 567. So I think the number could be in any of these kind of two ranges. My sense is that it's probably closer to this like 300 number, but I cannot necessarily rule that out after a bunch of accounting exercise that we've done. Okay, so let me show you some evidence of the actual reform with people kicking out. So this is raw data. I haven't done anything to the data. This is data that I collected from the Department of Health in Tennessee, which reports the number of people enrolled in TennCare over time. It's important to notice that before 2005, they only had information recorded annually. So that's why you see those dots and it's a little bit more noisy. But starting in 2005, they started collecting monthly enrollments. The reason why this happened is because they wanted to see how this reform is going to affect people. So they started actually counting people every single month. And what you can see is that, so this was announced, I think in April, going in at the start of August is when people started like losing Medicaid. And that's exactly what we see here. At the start of August, the number of people that are enrolled in TennCare just tanks until about stabilizes of April of 2006, in which that finishes the window of determination of eligibility. So that's kind of like that big reform that I'm going to use and study. You'll notice that there's a period of time that it's kind of like the during period, or kind of like the rollout of that. So I'm usually in all my specifications, I'm just going to compare before the first line and after the second line to make it much more clear in that way. You can dummy these things out as well, and you'll see that in the event study. It doesn't really make so much of a difference. But this is kind of showing you the stark change of the reform. One thing that is important, and I'll mention this here because there has been some papers around the other TennCare papers saying how they didn't find some of the stuff that they would have found. I think one thing that is important to consider is that in this reform, okay, you have about, let's say, 200K people losing health insurance. How much are you going to get picked up on the surveys like BRFIS or National Health Insurance Surveys so that you can actually find an effect in here? So that's a great question. And my sense is two things that, so we definitely see it in a lot of those surveys. And I think we see it because it's a sharp and a little bit sizable decline. And that's why we were able to detect it, but we're not able to detect a bunch of different changes in all the other outcomes. So that's why in some of the papers I've written, I gravitated towards using admin data, because then or data that has essentially a lot more N, because then you're able to pick up a lot more of this stark change. Okay, so one important question too is who got dropped? Like the people who got dropped, what do they look like, right? And so here are some estimates. And I'm comparing them to 3 other reforms that have been broadly studied just to see how they differentiate between those two. So OHE is the Oregon Health Insurance Experiment, Massachusetts Health Reform, the ACA Medicaid expansions for childless adults, and then TennCare disenrollment. What you'll notice, and I have highlighted in blue, is that TennCare disenrollment seems very similar to the population that got expanded Medicare eligibility during the ACA. Makes sense because if you notice the first line or the second line, sorry, the majority of them are childless adults, right? That's what that's saying. The majority of these people were childless adults. No surprise there because of the eligibility changes. And I think this is interesting in the sense that if we are ever thinking of living in a world in which the ACA Medicaid expansions could get repealed or through budget deficits contracted, we can look at this reform to understand what could happen. And I think that's something important. In terms of age, we're looking at a little bit of an older population. So about 70% of my sample is 35 and above. About 60% female, mostly white, and with lower levels of education. We have about like 80% of our sample being high school graduate or less years of education. So you can kind of have an idea of like who's that particular population. Older childless adults, sometimes female, white, and lower education. And you can subsample in a lot of the surveys that one could have on these types of characteristics, and you'll see that the effect is much, much bigger there if you were trying to detect stuff. So what data are we going to use? So we're using the nationwide inpatient sample from HCUP. So this provides information on inpatient admissions that happen in a sample of hospitals. This is not, all hospitals in the United States is about 20% sample, but for each hospital, we're in theory supposed to have all their admissions in a particular year, in a particular quarter. And what we're going to do with this data is, so you can grab this data and run your DD, your difference in difference that you want, and compare Tennessee to other southern states. The challenge is that we know that this data is not state representative, it's only region representative. So it's representative of the South, it's representative of the Northwest, and so on, with the ways that they have. And so what we did is we went and got very similar data of hospitalizations, inpatient hospitalizations in Tennessee from the state of Tennessee, from the Department of Health. We didn't get as detailed as NIS has, we just kind of got counts based on a set of diagnoses that we gave them. And so what we're really doing is we're grabbing that Tennessee administrative data, which is obviously state representative because it's like the full data of the state, and essentially imputing it into the NIS as a replacement for the NIS Tennessee data, and then running things together. And the reason why we think this works is because our treatment is Tennessee, that's state representative because we have the admin data, and our control group is all the other southern states, which also is representative of the NIS. In the data appendix, we go through simulations of what is this doing to the data and how this is affecting our betas. And long story short, we essentially think we're getting this closer to the potential estimate there, or true estimate. We're also going to use data from TEDS and the treatment episode data set, and the National Vital Statistics System to look at mortality outcomes. We also, in one version of the paper, focus a lot on NESTA, which is a National Survey of Drug Using or Drug Utilization, I believe, in healthcare. But we're not focusing on that as much anymore. So let me show you just some raw figures of how this thing looks. So this is, for example, the number of mental health discharges. So we have a hospital, we have information of admission codes, and we get through different papers or literature a number of ICD-9 codes that are related to mental health or of that flavor. And this is also it's not very sensitive to adding one more code or taking one more code away. So we're just counting those, and we've seen how that evolves over time. So you can see that there is an increasing trend for Tennessee and all the other southern states on the number of inpatient admissions that are happening. Just to highlight how do we use NIS, this is how the difference would have been. So the rhombus, so this thing right here is the Tennessee NIS, and you can see that it's very noisy. Change is very volatile, whereas the administration data is a lot more, still relatively volatile, but much more flat. And I think this is important for this particular context, because look at what happens in 2005, right after in NIS, it just goes straight up. So we would have identified probably some sort of, weird pattern and effect. And so we think that using the admin data is a lot more helpful. All right, back to this. We also separate and do the same exercise for substance abuse types of inpatients admissions. Again, similar patterns. We're seeing that things track really well before the reform, and maybe you squint, there is something there, but we're gonna let our regression see if there's anything particularly different there. And this is just total discharges. Okay, so as I said, we're gonna run a very straightforward difference in difference where we're comparing Tennessee before and after to other southern states before and after the reform. Identifying assumption here is that Tennessee would not have evolved differently to other southern states in the absence of the disenrollment. One awesome thing about this setup is that I don't have to worry about the new literature on difference in difference, because it's just a very straightforward, almost 2x2 type of setup. We're gonna put year fixed effects, quarter fixed effects, hospital fixed effects. So we're comparing within hospital changes of what happened in Tennessee. And we also have a number of state controls. We can take those out if you don't like them. Things about demographics like education, age, and employment, poverty rate, TAM, SNAP benefits, EITC rates, state by year demographics, PDP. So we're trying to put essentially a lot of the state by year things that we think could be confounding a relationship. But fortunately for us, whether you add or subtract any of these, it's not going to do too much to our estimates. And we're using the provided hospital weights. All right, let's get into some results in the last 20 minutes. So the first thing we check is, does the number of hospital changes change, right? Is the number going to be really different? Are we seeing more or less? And to our surprise, or at least my surprise, maybe I shouldn't talk for my co-authors here, we don't see any meaningful change, whether economically or statistically significant change in the number of mental health or substance use of hospitalization. And so we thought that was a little bit interesting in that we would have expected to go in one direction given the other results that the literature has found, but we didn't see any movement there. We can see the event studies of this. They're okay. I'm not going to sell you an effect here, and it's actually somewhat noisy too. So you can see them. They just look like there's nothing there. So that's our conclusion, that there's nothing really precise to uncover there. So we were like, okay, so maybe the number didn't change, but maybe the composition of the people who are coming in change, or more about their insurance. And so we started looking at what is the percentage of these hospitalizations that about related to mental health that come in with a Medicaid insurance payment, right? And this is an event study. I'll show you the table of the difference. Maybe I should explain what this is doing. What each point here is doing is comparing Tennessee and the southern states relative to a particular time period that we picked. And the idea here is that before the reform, we want those things to be zero or close to zero, because that means that at every single point, the difference has not changed over time. So the difference could be, 5, but that difference is not changing over time. And that's what we're seeing. And then right after the reform, we see a divergence, which means that presumably Tennessee or the southern states, but in this case, Tennessee is divergent from that particular trend relative to that period time. So it's telling us a little bit of the effect and the dynamic effect of what is happening. What are we seeing here? The effects of the reform, right? People lose Medicaid, people are still going to the hospital or being admitted for these conditions, and now they no longer have Medicaid. The estimate here, I think, is going to be about 9 percentage points. That's about a 26% effect reduction in coming with Medicaid insurance payments. If we look at self-pay, so kind of like if you want to think of uninsured, that's increasing, right? So people are now more reporting more self-pay. That makes sense. If I'm not coming from Medicaid, I'm going to increase in self-pay. The other line that is kind of increasing is other category, which includes maybe charity, maybe donation, maybe the hospital picked the bill. But it's a little bit much more noisier, so it's kind of harder to say something more definite. And then finally, any insurance, right? So there could be some crowd-out effect. If you see the difference between Medicaid and any insurance, they're actually not on top of each other. That should tell you that there is some crowd-out effect from either private. It is coming from private or Medicare, depending on certain populations. It's unclear to us why that would happen so much, but at least that is what we're seeing in terms of the data for mental health hospitalizations. These are the numbers of those different deaths. So you see a 9 percentage point decrease in people reporting Medicaid as their insurance, 4 percentage point decrease in any type of insurance. This is split half and half between private and Medicare. And then self-pay, we see that increasing. It's not as statistically significant with our current adjustments, which I have not talked about what we're using for standard errors. This is not a great example of what you're supposed to be doing, in the sense that usually the bread and butter is you cluster standard errors at the state level and you're fine. We have one state treatment. We have 14 other non-treatment. There's a bunch of things that violate the fact that we're supposed to use clusters and the errors. So we actually have a table where we use a number of adjustments. These are coming from a method called block bootstrap. I'm not going to go into the details, but we did some Monte Carlo simulations to test that the rejection rates of these standard errors corrections seem reasonable, and that's why we went and used them. Again, not super fun to talk, so I'm just going to skip that, but hopefully you can trust us that we did a decent job in trying to find the correct standard errors adjustments. For substance abuse hospitalizations, again, we see a decrease in Medicaid payments. That makes a lot of sense. This is the effect of the reform right there. Self-pay increases way more, right? So you can see how symmetric this is for the case of substance abuse. So that should tell you that you should not expect as much crowd here. And that's exactly what we see here. For any insurance, the line between any insurance and Medicaid is not as different as it was for mental health. So we are seeing that for these cases, it's a lot more like you lose Medicaid and you're really coming into the hospital with nothing. And obviously that has its own repercussions for economics and also your mental health. So we're finding stronger effects overall for substance abuse type of hospitalizations, about a 12 percentage point reduction in Medicaid, 10 percentage point reduction in any insurance, and about 9 percentage points increase in self-pay. So a lot of it, we think it's being transferred to self-pay, and also because the private and Medicare are so small, the other category is the one that it's channeling things into. Finally, I can show you for all hospitalizations, just not any, like the mental health is just every single hospitalization. And again, we see a similar pattern. There is a little bit more crowd out too, or kind of like mild crowd out as well. But again, what we're seeing is that people are coming in with less insurance overall, obviously less Medicaid, and more self-pay. In this paper, we don't necessarily talk about the economic implications of this. But as you all know, if you walk into a hospital, especially have an inpatient stay while you're uninsured, that's going to be a not cheap bill. And that could definitely have financial consequences. And a team of co-authors that we have a paper on the financial consequences of this. And it's not great. That's the summary. There's a lot of bad things that happen. So these are the numbers for that: 7 percentage point decline in Medicaid, 4 percentage point decline in any insurance, and so on. So I think you guys get the gist of this. So we wanted to look at other outcomes. It's like, okay, so we're seeing this change in the composition of payment for mental health and substance use, sorry. So we look at TETS, this is the treatment episodes kind of data. Our N it's kind of small, so we didn't really think we would have enough power to detect something, and lo and behold, we don't. But it's trying to maybe show in terms of the size of the effects that there's a little bit of more of those things happening there. So in the inpatient side, maybe we're not seeing those changes that we thought we were, but in the TETS data we are seeing. Again, very suggestive. I wouldn't make so many conclusions on this. When we look at mortality, suicides, we see a positive, but again, it's a small coefficient. The only thing we get some traction on is on mortality due to fatal alcohol poisoning and drug overuse, and that's an increase as well, suggesting that this reform may have some adverse consequences in terms of mental health. Again, because of the type of data, we're not exactly. I think we think this is suggestive rather than anything else. We can show you, for example, with the Nesta, that the probability of you receiving mental health treatment is also decreasing. Again, we don't have great data to go back to show you a nice pre-trend, but it's suggestive with this idea that what we think is happening is people losing Medicaid, they're receiving less mental health treatment, and either you end up, or you still have to end up in the inpatient side, being uninsured, or maybe you have a worse outcome, as we see in the mortality data. Okay, so as we do in econ, we have to show you that our estimates are robust to a bunch of different things. I thought that what a fun way to show you by just showing you my baseline estimates and a number of robustness things that I ran in different specifications to make sure that this is stable. What we're doing here, and I'll go slower, we're dropping to 2005, that kind of like during period. There is a weird blip in the data for NAS in 2007 quarter 2 that we haven't figured it out very well. We still include, 3 and 4, we still include it in our main analysis. This is one version where we drop it. It doesn't seem to make that much difference. This is going past the recession. So the reason why we stopped in 2007 is because we did not want to step on the effects of the recession, because that may actually violate our assumptions. If we include it in, our effects are a little bit basically bigger, so we're being a little bit more conservative. We dropped Texas and Georgia mostly because of big sample sizes. We do no weights, stay linear time trends, no covariates. aggregation at the state level. And overall, what we're finding, so the orange and the confidence intervals, those are from the baseline. There's some gray X's there. We're finding that our estimate seems pretty robust to a number of alternative specifications that we ran across the board. And I think I can show you the same for SUD. You see here a number of specifications. The ones that are a little bit further out, those are the ones that are 2000 to 2010, so including the recession as well. But mostly that they stay within that confidence interval. We also try to do different inference adjustments. I can show you cluster. We also do randomization inference. And I don't want to say it passes, but the idea of randomization inference is your value at the extreme values if I randomly assign treatment to all my units and to mostly all of our coefficients, we're finding that particular thing. So if we show you something significant because we think something is statistically significant. Another question that we get asked a lot is about migration. Like maybe what this reform did is that people lose Medicaid or this reform came and I am going to migrate to a different state. So without running any regressions, the reason why I don't think that would happen is that all the other states had worse Medicaid eligibilities than Tennessee, right? Tennessee was the generous one and just going back to normal. So there's actually nothing to gain from going to a different kind of state. Maybe some reason about work or employment or something like that. But we don't see that in the data as well, right? So I think theoretically, or at least in terms of the context of the policy, it did not make sense for people to migrate. We don't see that in the data as well. We talked already about this, about the difference between NAS and Tennessee, and how we use that data, we would have found probably different results. And the reason why we are making somewhat of a point about this is that there are some papers out there that are just using that for single state analysis. And so it's more like a cautionary tale. We don't think it's like, oh my gosh, you should definitely not use it. We just think that in our case, it didn't work so well and it could have confounded a lot of stuff. And so we just want to buyer beware of using that. Okay, cool. So conclusions, we find decreases in coverage for Medicaid and any insurance for mental health and substance use hospitalizations. We don't find strong evidence or changes in mental health hospitalizations or SUD-related hospitalization. Some suggested evidence of increases in unmet healthcare, no real changes in overall suicides, but some suggestive increases in fatal alcohol poisoning that could indicate worsening of mental health for individuals. I can show you, the estimates using NIS only, but I think I'll skip for that. And I'd rather show you this table related to symmetry, which I think is interesting. So, one of the things that when I started this project is thinking about the difference between gaining and losing health insurance. And so what I've done, and actually there's a way better version of this table in another paper of mine that is published in the Southern Economic Journal, where I go and do a better exercise of this. But this is just comparing percentage changes of what people found in the Oregon Health Insurance Experiment, which is what one consider kind of like a cleanly identified, quote unquote, experiment of people gaining insurance versus the 10-kill disenrollment. And across many different kind of like aspects of health. So self-reported health, that seems pretty symmetric in my eyes. Obviously, they're going to be a little bit different. Healthcare access, again, we're finding pretty symmetric effects. Preventative care, this is one that is a little bit odd of why that is not symmetric, and it's unclear why. EDUs is also not great. This is using admin data. This is using survey data. So usual caveats. Inpatient visits, which is why we've seen here, they are on the borderline of being symmetric or not. We're seeing a little bit less. There's also credit scores and bankruptcy. So I think the point of this thing, and I've done a better comparison with the ACA Medicaid expansions, which I think is like the more right reform to compare it to, is that in some aspects there's going to be symmetry and in other aspects it's not going to be symmetry. And it seems to be that part of the reason why that's the case is about there are certain things in certain contexts in which you already have an insurance, and having built a lot of potential health capital information is going to make it so that when you lose that insurance, you still have that health information and knowledge about how to navigate your conditions, or have made connections with providers that may lessen the impact of losing health insurance as we previously thought, which could be interesting. But I think that's definitely something that we can explore and understand a ton more. But thank you so much for having me. Happy if you need to go, and you can write me an email or tweet at me or anything. Thank you so much. Appreciate it. Okay, yeah.
Thank you. It was a really interesting presentation. I had a question about the increase in Medicare coverage being part of the mechanism, it seems like.
Yeah.
And I was wondering if that's a little bit different, if you thought about does that differ in the case of mental health care versus other types of healthcare or that you've been studying. And I was also, it seems that there was a difference between substance use and other types of mental health inpatient care. So I was just wondering if this is just, a feature of our healthcare system, that there are certain diagnoses where there's some substitutability because you could be qualified for Medicare, and perhaps the hospital could help sign you up for that so they could get paid better. If you thought about kind of dividing the diagnoses along those lines based on, for example, the proportion that were paid by Medicare at baseline or something like that.
Yeah, that's a great question. I think I don't have a good answer. So my answer is that, okay, if we think of how you become Medicare eligible, there's a number of ways. Obviously, it's over 65, renal conditions that you may have. I think I'm forgetting the two others that are usually in my head. And long story short, when we look at the data, what we can say is that it's not the 65 thing. It's not that these are like dual potential eligibles doing this. It has to be any of the other Medicare eligibility parts. We don't know which one of those is, but it's potentially some of that. And I think that's the best answer that I have. And like the answer is truly like, I don't know what is that mechanism that is working so that they see increases in Medicare. I do have to say that I think we only see that in this particular context. So when I've used other surveys, I don't see Medicare popping up as higher as it did in here.
Great. I see a question in the chat. So Justin says, sorry if I missed this, with the null effect on hospitalizations being something of a surprise, what was your prior based on prior literature of which direction it would have gone, losing Medicaid or up or down hospitalizations for MH?
Yeah, that's a good question about my biases. I would have thought, so okay, to be honest, I had two reasons for going either direction, but I thought it was going to be a change. So that's why it was a surprise that it was no change. So you can think one hypothesis is people are losing insurance, they're losing their primary care access, maybe access to mental health care and so on. And therefore you're going to appear more in these extreme cases of inpatient hospitalization that we see. You could also think of the other way of like, well, I'm losing health insurance and I'm maybe less likely to appear in a hospital because I'm trying to avoid that particular inpatient stay. So I think the surprise was that it was kind of flat as opposed to a drastic one way or the other.
Great. Now John has a question.
Thanks, Sebastian. That was really interesting. I have a question about non-hospitalization forms of care that might have been changing during that period. And I guess I'm asking more for speculation than for anything you can get out of your data, but sort of two questions. One is, do you have your last table got at sort of the macro view of emergency departments and preventive care and so forth. Do you have any ancillary information on whether there might have been shifts from inpatient to outpatient care or to pharma treatment or no treatment at all? And the second part of the question is, that notwithstanding, is the reason to think in Tennessee that there might be geographical variation in the way this plays out? In other words, are there parts of the state where the availability of non-inpatient forms of mental health care may be much more restricted than in other parts of the state?
Yeah, those are great questions. So to get at your first one, there's a great book, but by actually a Vanderbilt scholar on this particular 10-care reform. And the thing that I learned from that, and also from just talking to people in Tennessee about this, is that for the particular case of mental health, as people were losing potentially access to service, there was an effort within the state to try to provide or transition people with mental health care needs. So as in like, for people who had physical health needs, like there wasn't much of like a support done. But for mental health care, there was at least people within the State Department of Health that were trying to put initiative of like doing something. What is that something? It could look like maybe transitioning from somebody who had a therapist to another therapist that works with pro bono or something like that, or support groups or anything. That's only documented in like reports. And there's nothing, unfortunately, empirical that I can show you that existed and it was broad and that mitigated everything. But that's something that I think it's important to know. There was a survey that the state did that asked people about their healthcare needs being met, and they do report an increase in that. I mean, it was just like the question was phrased like, has it been harder for you, right, to find mental health care? And everyone's like, yes, it's much harder. So like, it's kind of, to me, I don't know what to make of that information other than like, within the state, there's some maybe safety net that was trying to be created, but empirically it's kind of like somewhat hard to show. So that's to your first point. To your second point about geographical variation, so I think that could definitely be the case. I think that, so across counties, there's variation in the amount of people that were dropped from Medicaid, right? And that's not a surprise. Some counties may be richer than others, and so they're potential Medicaid. Now, within that, there's also like this potential correlation that more rural areas, lower income, you're also less likely to have access to a mental health provider. And so those things could be correlated. And it's a little bit hard to disentangle. We tried to deal with this data by urban and rural cuts, where you get into a lot of like power issues and representativity issues that didn't make us really comfortable in showing the empirics of that. So I think to answer your point is, yes, there could be some of that. We have not had the at least data structure to take advantage of that.
Thank you.
Yeah.
Thanks for that, Sebastian. My question is about the information rollout for how people figure out that they no longer have coverage, and whether there's anything you can do about this issue that presumably some people didn't know the first time you see them going to the hospital. And then in some sense, that's the treatment that they figure it out when they're at the hospital, and then you would follow them up. Could you speak a little bit to that?
Yeah, that's a great question. So the way the state let people know is that they send letters in the mail saying that your Medicaid eligibility will be terminated and not be able to be renewed, because obviously you renew Medicaid every single year. Those letters were rolled out starting, I think, May of 2005 throughout up to probably not April 2006, but like a little bit before of April 2006. When did those people get the letters? Like a specific person, I don't know. So that more nuanced version of like, oh, did they find it in the hospital through a letter? It's hard to know. What I would say is that I think if there is anything about an anticipatory effect, like let's say, oh my gosh, I know I'm going to lose Medicaid, I'm going to go get this stuff. I think that could happen. I have not seen it in any of the data, right? Because what you see in something like right before jump in. And so if it did, it's maybe a very, very small set. So it seems like it's not, I think people knew they were going to lose it, but it's not like they behave anything differently for those particular reasons. Yeah, at least data-wise.
Thanks, Sebastian.
Yeah.
So I'm still trying to puzzle through this kind of null effect with the hospitalizations. And
Yeah.
I'm wondering if you could, and maybe you've done this already because you've probably done like a gazillion other things here that we haven't seen, but could you look at inpatient hospitalizations that started in an emergency department? So, inpatient is generally less discretionary than other kinds of care, but it's not entirely discretionary. And so I just wonder if you would see the same, like that's where you might expect no change, right? But
Yeah.
maybe there's changes in somewhat more discretionary inpatient.
Yeah. The answer is, it's unfortunate that, so with NAS, we can see that, but we also need the Tennessee admin data to tell us that. And they are not, or have not yet given us, even though we asked. And so, I don't know. I think it's absolutely interesting. I think we want to study that. And we're trying to see if, as there's different directors of the Department of Health, they would let us, but so far, no luck.
Thank you, Sebastian. Yeah, I just was wondering, during the same period that you're talking about, we've had what people call the epidemic of despair. And I know that was even before the COVID. Now, I don't know what era we're in. It's got to be worse.
Right.
But I just was wondering, is it possible that, changes in Medicaid funding for hospitalizations had a relatively trivial impact on these things, on mental health, than some of these other bigger issues like globalization and whatever else is behind the epidemic of despair. And maybe that's why you can't find it.
Yeah, so sorry, let me see if I understand. So a potential hypothesis is that Medicaid doesn't really, we're not finding an effect because Medicaid didn't really affect this as much as any of the other factors that could have. I mean, that certainly could be the case with the design, right? We're essentially assuming that because trends are parallel between Tennessee and other states, that if all the other states are also getting affected by this, we're netting that kind of stuff out. Because otherwise, why would they be evolving similarly if they're it should be evolving really differently? So in some sense, we kind of think that hopefully our identification is netting that out and just relying on the difference that Medicaid could create. But even if that's true, it could be that yes, maybe Medicaid doesn't have the effect that we think it has. I think this is where it gets a little bit difficult in the sense that there's a literature about gaining health insurance that is finding some of the effects. And so why is it that we're finding something different? And I think that's where the conversation would go. Mm-hmm.
Thanks for an interesting talk. I had two questions that sort of go in opposite directions when you try to estimate the potential savings for the state.
Oh, yeah. Mm-hmm.
The first is that it would appear to me that the people who were actually being hospitalized for mental health reasons are likely to have above average costs.
Mm-hmm.
So that the people who were most directly affected may be people who have higher than average costs. And so that would be an underestimate. And I don't know what your views are about that and whether you can better refine that. On the other side, I mean, it's clear that some of these people, as kind of John suggested and others, are getting care someplace. So if they're getting care someplace, those costs are being picked up somehow. And so the state presumably is somewhere paying for part of that. And so the savings, when you look at it in terms of Medicaid, are going to overestimate the actual savings because there's going to be payments in other places, and there may be consequences for workforce participation as well.
Absolutely. So those are great points. So let's tackle them one by one. So the first point is about an underestimate. So essentially, virtually all of these enrollees are in managed care organizations, means that the state is presumably paying a somewhat fixed cost per patient. And so they're potentially not being burned by this volatile change or high expenditures. Maybe there's obviously some adjustment that I'm not seeing in the way they do insurance contracts. And that's where your story makes a lot more sense. So yes, it could be an underestimate, but what I don't know, I'm taking the average thing that they're spending per person across a bunch of the MCO contract plans. If there's adjustments made that are done contract by contract, absolutely, that could be the case. I'm not seeing them, so this is just an approximation for that. So that's very fair. And the second point about who's paying, so that's an excellent point. It's unclear to me if the state is fully paying for all of stuff like that. And the reason why I say this is for the empirical evidence that we have. So in one of my papers, we look at credit reports and credit card bills, and essentially what we're seeing is a lot of unpaid bills that people are, or what we think is happening is that people are putting their hospital bills on their credit cards and then obviously delaying that payment, or people are not paying their mortgage on their cars in order to pay that hospital bill. Now, another paper that somebody else has done that is related to this, they see that hospital, unpaid bills is increasing. So what we think it's happening partially at least, or that we can detect empirically, is that the hospitals are they're essentially not getting their money paid, and the state is not paying them either. So the state has a fund for unpaid bills that hospitals can go and claim is a very, very, very small fund, runs really quickly every year. So that does any budgets on the savings. So I think in terms of, so the state in that sense, if you just think of that world, maybe saving because the hospitals are the ones bearing that burden now. It could be the case that there's also other things that the state is doing that is not necessarily saving as much money. Absolutely, that's definitely could be the case. Those are a little bit harder to quantify. And I mean, if they're not categorized as health expenditures, we wouldn't see them. But that's why I do the other comparison, which is like, let's just state health expenditures. How much did it decrease? And that's the 500 number, right? So that's like if the state is doing something else to support them and is categorizing that as health, then we would see that going up in the state health expenditures, unless it's put into a different type of expenditures, and that becomes a harder accounting that I have not done. Oh, that's a microphone? Oh, that's so fun.
So did you by chance look at sort of the intensive margin? So how long the hospitalizations were and not just, I mean, obviously any hospitalization is going to be, a big deal and expensive, but I'm wondering if there was a difference in.
Yeah. Again, the unfortunate answer of we can do it with just NAS and look it up, but we do not have the data for the Tennessee part. So in NAS, you're seeing a little bit higher length of stay. If that tells you anything, but you've seen what I show you with just NIS Tennessee, so it's always hard to make those inferences.
Any more questions? Anybody on the Zoom either? All right, I don't see any hands raised. Sorry about that. Thank you so much for your talk.
Thank you. Thank you, everyone.